So welcome everyone. We have a super program for you tonight in this, the first of the RBMO sessions for the coming season. They're always, I think, characterized by an eclectic range of topics and speakers. And we really have a super lineup for you this evening. And I'm delighted to be joined by two very distinguished co-moderators for this evening, both with a very strong and important link to RBMO. Signe, who's been saying hello to you, I've known for many years. She's an associate professor at the Department of Biochemistry and Molecular Biology at the University of Granada in Spain, and a visiting researcher at the Division of Obstetrics and Gynecology at the Karolinska Institute in Sweden. She's got broad research interests, focusing primarily, I suppose, on molecular aspects of endometrial receptivity and how molecular dysregulation could impact embryo implantation and female infertility, such an important area of research. And we're also joined by Catherine Aiken from Cambridge, who's a professor of maternal and fetal medicine at the University of Cambridge, where she leads a group studying the long-term outcomes of complex pregnancies. She is a section editor on our section of RBMO, Periconception, Pregnancy, Children Outcomes, and she will be telling us a little bit about the section earlier. But I'm going to hand over to Signe now, who's also an editor of RBMO, so delighted to welcome Signe too, to take the meeting into the next phase. Thank you, Signe.
Thank you, Nick. Thank you for the introduction. It is my pleasure to host this webinar together with Professor Nick. And when talking about the bio and backgrounds, I would say, yes, we know for many years. And before knowing him personally, I read many papers from him, his research group. So it's a real pleasure to know in person and to share some new experiences in the Journal of RBM Online. So I believe that all of you know Nick Macklon, but I will make a brief introduction. Nick is a Group Medical Director of London Women's Clinic, London Egg Bank, and London Sperm Bank. And he has held full professorships and department chair positions at different universities in Europe, at the University of Utrecht, Holland, Southampton, UK, and Copenhagen in Denmark. He's a former member of ESHRE Executive Committee and coordinator of ESHRE Special Interest Group of Reproductive Endocrinology, and now a co-chief editor of Reproductive Biomedicine online journal. So before we start the session and go to the speakers, there are a few points I would like to raise. One is just to say that this webinar, together with the previous webinars powered by i3, available on the website ivfmeeting.com, and also the full bios available of tonight's speakers on that website. Another information for the audience, important information, is that we do provide certificates of attendance of this session, but please be patient. They will be posted in a few days, not tonight, not tomorrow morning. It will take a couple of days. And I hope you will enjoy the webinar. I hope you will have many questions. And all the questions that you will be having, please place them in the section of QA section and not in the chat section. In this way, it will be easier for us to follow the questions. And the questions we will be raising in the end of the panel discussion after the presentations. So saying all this, I think we can begin with the first speaker. I'm honored to introduce Dr. Münevver Serdaroğulları from Cyprus. Münevver is a senior clinical embryologist with over 16 years of experience in Ventus IVF Center. Her primary research interests encompass male infertility, time-lapse technologies, and cryopreservation. And she has taken on different responsibilities within the ESHRE, activities belonging to ESHRE Journal Club editorial team, ESHRE Male Reproductive Health Initiative Core Working Group, International Reproductive Health Education Collaboration Steering Committee, and recently, ESHRE Female Reproductive Genetics Initiative working group. Münevver joined us on behalf of the author team behind recent review paper published in RBMO journal entitled Revitalising Female Fertility, Platelet-Rich Plasma, Hype or Hope. Please, Münevver, the stage is yours.
Yeah, I would like to thank you for the RBMO and the IVF for the invitation. And I am honored to be here tonight. So, as Signe presented, my name is Münevver Serdaroğulları, and I'm a senior clinical embryologist. And currently, I work as a scientific director in Windt IVF Center in Cyprus. And also, I have active duties in Israel. Today, I'm going to present our latest paper on PRP. The title is Revitalising Female Fertility, PRP, Hype or Hope. So I would like to start with the introduction. And so, as we all know, platelets are the small, disc-shaped cell fragments in the blood that play a key role in helping to prevent excessive role in bleeding when we get injured. They are a crucial part of the body's clothing system. They do more than just helping with the clothing. They also release growth factors, cytokines, that they are important for a bunch of biological processes like cell growth, forming a new blood vessels, and even controlling cell death. Also, they are thought to play a role in tissue repair, wound healing, and regeneration of the blood vessels. So the process, as we all know, the process of platelet-rich plasma isolation begins with taking a small blood sample from patients. So what we do is that we use the centrifugation steps to separate the platelets-rich plasma according to its density. Once we have the concentrated PRP, the platelets must be activated, then injected into targeted area of the body that require treatments. However, the effectiveness of PRP in medically assisted reproduction is still a topic of debate. In this review, we take an objective look what we currently know, including the outcomes and implications of the PRP using in this field. Let me walk you through the materials and methods we use for this study. For this study, we had a time frame up to December 2022. So we primarily focused on original research papers. We specifically excluded the abstracts, case reports, and case series from our analysis, especially in areas like endometrial thickness, ovarian regeneration, and repeated implantation failure. The only exceptions were studies related to Asherman syndrome and the chronic endometritis. So we ended up 36 original papers, and these papers are mainly from Iran, Turkey, China, UK, and Ukraine. So we divided them into the categories. So 11 papers studied ovarian regeneration, 12 of them endometrial thickness, and 11 repeated implantation failure, and 2 of them were other indications. Let's dive into what we found with the treatment, PRP treatment with the thin endometrial lining. So there are 11 studies that especially look at the using intrauterine PRP infusion to treat infertile women with thin endometrium. I know my slides, my tables are a bit tight, but the paper is free access. So when you have free time, you can just go and look at the tables. So when we look at the study designs, only 2 of them are randomized controlled trials. So when we analyze the papers, most of these studies on impact of PRP treating for thin endometrium have reported positive outcomes. Generally, the treatment has shown favorable results, making it a promising option for improving the endometrial health. Out of these 11 studies that we reviewed, 9 of them reported favorable results with the PRP treatment for thin endometrium, and while 2 studies found no significant difference with the outcome. Let's shift our focus on the results of using PRP for ovarian regeneration. So during our research timeline, that it is ended up December 2022, we found that 12 studies explored impact of PRP on ovarian regeneration in the context of IVF. However, it is important to note that none of these studies are RCTs. Most of these studies highlight the positive impact of the PRP on ovarian regeneration, showing promising results. However, there are also studies with negative or conflicting findings regarding its effectiveness in improving ovarian function. Out of the studies we reviewed, 9 reported favorable results with the treatment for ovarian regeneration, while 3 studies found no significant difference with the outcome. As I mentioned, until our research timeline that ended December 2022, regarding this topic, there wasn't any RCTs. And recently, to the best of our knowledge, 2 RCTs have been published on poor ovarian response patients. So I'm not going to give detailed information about these papers, but they have different outcomes. And when you have free time, if you like, you can go and check in detail. When we examine the results of using autologous PRP for patients with recurrent implantation failure, we see a range of outcomes. So the research on these topics includes 6 observational cohort studies and 5 RCTs. So most of these studies found PRP treatment leads to higher pregnancy rates for the with the patient with RIF, suggesting it might improve the fertility outcomes. However, these studies differ in design and scale, patient demographics, which can affect how we interpret and compare the results. So while there is a generally positive trend, the effectiveness varies. So this variability highlights the need more standardized research to clearly determine how effective PRP is and how to best use it for treating RIF. Out of studies that we reviewed, 8 of them reported favorable results with the PRP treatment for RIF, and 3 of them found no significant difference with the outcome. Finding our review shows conflicting outcomes in terms of efficacy of PRP in all categories that we assess, either being ovarian regeneration, endometrial thickness, and RIF. Now, let's continue by looking at the protocols for preparing PRP, especially for use of ovarian endometrial procedures. So we went through the PRP protocol step by step. We outlined the similarities and the differences in how PRP prepared for various uses. So it is described in this table, but again, my table is tight, but you can freely access this table in detail. So with the preparation of the protocols, we observed the lack of standardization in the preparation of the PRP. So for the ovarian injections, the initial blood volume taken from infertile women range from 8 to 50 milliliters. But when it comes to with the uterine cavity injections, the initial blood volume range from the 8 to 22. But on the other hand, one of the study that which was performed by Fadad and his colleagues in 2019 found the concentration of PRP after proceedings tends to have a moderate positive correlation with the initial volume of blood taken. Also, none of these studies will look at the reported initial PRP concentration from the participant. One study used PRP to improve endometrial thickness that specifically mentioned the initial concentration of growth factors, not the initial platelet concentrations. For the final platelet concentration, one study reported that the final concentrations of the platelets in PRP for ovarian injection was around 1 million platelets per milliliters. 5 studies report the final platelets concentration for endometrial preparation. The values in these studies were varied, ranging from around 900,000 to 1 million to 1,500,000 platelets per milliliters. So when we look at these final platelet concentrations that differ, determining the optimal platelet concentration of PRP remains unresolved issue. For the PRP factor increase from the whole blood, it is important to note that the lack of studies evaluating both initial and final platelet concentrations makes it difficult to assess the increase in PRP factors derived from the whole blood. So 60 studies reported 4 to 5-fold increase in concentration after preparation, but they didn't provide any specific values. However, one study showed 4.7-fold increase in PRP factors, but another study precisely calculated 4.25-fold increase in PRP compared to whole blood. So, without determining this factor increases, it is challenging to accurately evaluate the efficacy of different PRP preparation protocols. When we look at the centrifugation force and the time, the papers that we analyzed, some of them use first 2-step of centrifugation, some of them use one-step centrifugation. So for the 2-step centrifugation, they used first centrifugation step is from ranging 250 to 800 G for 3 to 15 minutes. And the second centrifugation is from 1,400 to 2,000 G for 5 to 15 minutes. For the one-step centrifugation, it is around 1,000 and between the 1,800 G for the 3 to 6 minutes. In this particular context, a review article from Indian Association of Dermatologists and Venereologists, they evaluated 45 scholarly articles, including observational studies and the reviews. So they recommended specific centrifugation protocols for PRP preparation. So what they suggested performing the 2-step of centrifugations. First centrifugation is from ranging from 100 to 300 G for 5 to 10 minutes. And the second one was the 400 to 700 G for 10 to 17 minutes. These recommendations that they made are based on findings from previous research that identify certain manifestation and characteristics during spontaneous PRP preparation. So for the injected volume, in ovarian regeneration treatments, the reported volumes range from the 0.7 to 8 milliliters per ovary, while for the endometrial preparation, the volumes range from the 0.3 to 4 milliliters. This variation highlights the lack of standardization in protocols and optimal concentration for both ovarian and endometrial treatments. We also don't know the optimal volume to use, and higher volumes might be linked to mechanical damage. Additionally, published studies vary in timing and frequency of injections. In the papers that we analyzed, they used, some of them use commercial kits, some of them use in-house preparations, and some of the papers, they didn't even mention the procedure. So different protocols from various providers have led to varying final PRP concentrations. Even using the same commercial kits have reported significantly different results. So before I conclude my presentation, I would like to give some information about the biosafety concerns in PRP. I am sure that everyone is concerning it. So I would like to give some information about what is our current status in the PRP. So predominant literature focuses on therapeutic efficacy, but less on the potential adverse outcomes. I am all sure that you read the latest IVF add-on guidelines, which is performed by the extra add-ons working group, and it is published 2023. PRP is not endorsed by the working group. For the safety findings, to the best of our knowledge, no reported harm associated with the PRP utilization to date. And studies reported no side effect or complications in the reproductive drug. And also PRP shows potential as an antimicrobial agent, reducing infection concerns. And growth factors in PRP are non-mutagenic and they don't induce tumor formation. Concerns and gaps. Of course, we have lack of safety data on the effects of PRP on ovaries, endometrium, and embryos. And of course, we need for comprehensive long-term safety studies in our field. And for the future, it is very essential to establish a safety profile for PRP before we use in clinical routine in clinical use. And addresses also ongoing concerns about the potential link between the ART and birth defects. And of course, safety is first. For the conclusion, this exploration underscores the importance of standardization PRP preparation protocols in reproductive medicine. However, challenges persist and, of course, necessitating well-planned randomized controlled trials and deeper understanding of the patient population that stands to gain of most from PRP treatment. Clarifying these aspects is crucial for improving outcomes for the low prognosis patients and undergoing assisted reproduction techniques. And for the final short and long-term biosafety of PRP requires assessment. And I would like to thank you, the team behind this paper. I couldn't do without them. So together we rise, united success. So I would like to thank you for listening to me.
Thank you very much, Mona, for that very clear overview. I mean, trying to cover so much ground in such a short time is quite an undertaking, and you've even managed to update it with 2 more recent randomized controlled trials. So thank you for that. We'll be coming back. We've got questions coming in about safety and about different patient groups. I think before we move on to the next speaker, I think what would be helpful would be to understand your view on the extent to which, should we be using PRP? I mean, you've said that the add-ons group is saying no. I know in some countries it's quite popular. Is it being used a lot in your country?
In some groups, yes. For example, in Turkey, they believe it, but in some of the clinics, they don't believe it, so they don't use it. For my view, as an embryologist, and since we have been working on this paper a lot, so we objectively look at the results, and we can see, even with the recent published RCTs, we can see if you go and look at the protocols and the preparation of the PRPs, we have the lack of standardization. So even with the same group, we have different use. One of them use commercial kits, one of them prepare their homemade their protocols. The volumes are different. One of them has the 1 step of centrifugation, and some of them have, and another one has the 2-step centrifugation. So for my point of view, we need standardization before we use it, and more RCTs as well. Sorry. And also the papers that we highlighted, they are lack of, the patients, the numbers are less. So we cannot have like not conclusive comment on this one, and conclusion or use it or not use it. Yes. But I especially and instantly looking at the papers, we need standardized protocols for this one.
Yes, I think that's one of the great values of your paper, is to highlight that huge variation in practice, which is going to make it difficult, isn't it, to pin down. But from the time being, I think it's probably a reasonable conclusion to say that we should be very cautious about using it because, as you say, we don't really understand what the best protocol might be. And secondly, we may be doing more harm than good, and therefore more research is required. So I'd like to thank you for that. I think it's been really helpful for people to get that updated review on this very popular treatment, which many patients will ask us about, and I hope people will feel more informed about that, and we'll come back with more questions later. So thank you very much, Mona. So we're ready now to move to our next speaker, and it's a great pleasure of me to introduce a colleague of mine here at London Women's Clinic, Jemma Garratt, who's been with us for a few years. She originally joined as a research fellow and is now a data and insights scientist working with us. She's got a background in biological sciences and research, and she's currently doing a PhD with us in collaboration with the University of Kent. Although she's not a clinician, she's helping us with her data analysis to understand how we can improve clinical outcomes and what's really working in a purely clinical context. So one of the questions that she's been looking at is one that's been very controversial over the years, and many of you will be familiar with the discussions that take place in the media and elsewhere as to whether egg freezing, that we're increasingly being asked to do for women today and offering to them, does it work? It's all very well freezing eggs, but what are the chances when women come back, and how many women will come back, of actually being able to conceive from them? So Jemma's going to present to us a paper that was recently published in RBMO, which is an analysis of a very large data set over a number of years, which attempts to address both of these questions. So Jemma, I'll hand over to you now.
Good evening, everyone, or at least good evening from here in London. Thank you to i3 and RBMO for inviting me to speak this evening. And as Nick said, I'm going to be going through our recent publication, which is looking at our clinical outcomes of vitrified-warmed egg freezing cycles over a 15-year period completed at our single UK centre, the London Women's Clinic. So across the world, the global trend in egg freezing that we are seeing is an exponential increase year upon year. Today, I'm displaying two example sets of data that display this exponential increase beautifully. On the left-hand side, we have the SART American registry data, and on the right-hand side, we have our own clinic data. And what you can see is that in 2012, from the American registry, only 2,719 egg freezing cycles have been performed, which was nearly exceeding 14,000 by 2018. Similarly, albeit smaller numbers, in 2015, we had only completed 150 egg freezing cycles for our patients, which was reaching 800 by 2022. And I know that for 2023 and 2024, we have easily exceeded over 1,000 cycles now. The other trend I want to draw your attention to is the thaw cycles being performed year upon year, which, despite the number of egg freezing cycles exponentially increasing, this is remaining flat. And so we're seeing that despite increases in freezing, patients are not returning to thaw their eggs. And this is very much likely why it has taken a while for thaw cycle outcome papers to emerge. Particularly for us, it took a while to collate the data, or a large enough data set for publication. But I'm very pleased today that we have a manuscript out, of course, and I'm very excited to share the results with you. So I also wanted to look a little bit, before delving into all the thaw outcomes, is kind of look at the type of patients that are freezing their eggs, particularly at our clinic. And what I find is that our clinic, 88% of patients that are freezing their eggs are single at the time of freezing, and 12% in a relationship, heterosexual or same-sex. We then wanted to take this a little bit further, and we decided to use Garratt et al.'s 4 categories of egg freezers, which categorizes them into 4 key reasons why they froze their eggs, which are namely social, medical, clinical, and incidental. And to summarize these briefly for you, social is patients that appear to have no preconceived intention for treatment at that given time in their life, usually due to social reasons, and they're usually single. Medical freezers are usually patients that maybe are about to undergo chemotherapy treatment or a gender transition, and they need to cryopreserve their eggs. Clinical is usually patients in a relationship with preconceived intention for treatment, and they are usually batching their eggs for immediate thaw of all of them in one go for treatment. And incidental is when there is no sperm available on the day, so they have to freeze the eggs. And what we found is that at our clinic, 88% of patients are freezing their eggs for social reasons, 10% for clinical and medical reasons, and 2% for incidental reasons. And when we take a glimpse at the baseline parameters, we can see that they are freezing their eggs at a similar age. Their AMH is comparable, albeit incidental a little bit higher, and the average number of MET2s frozen is comparable as well. So between 2008 and 2022, we had 3,328 autologous oocyte freeze cycles performed. But we really wanted to focus on the patients that are freezing for those 4 reasons, the social, medical, clinical, and incidental reasons. And this reduced it to 3,182 cycles performed by 2,171 patients, which equated to over 36,000 eggs. And in the end, 299 patients returned between 2015 to 2023, completing 332 thaw cycles. And this equated to a 14% patient return rate. Now, spanning over 2008 to 2022, of course, there were variances in the vitrification protocol used, but I know that it was a form of the Irvine media kit that was used throughout those years. The primary outcome measure of this study is live birth rate, and it's calculated per embryo transferred, given that here in the UK, our governing body, the HFEA, requires that we report these statistics in that manner. But I have also provided cumulative rate per patient so that you can see how many patients are taking home a baby after completing treatment with us. Now, I've shown you the slide on the left, the graph on the left, but on the right is now the thaw cycle population, the N of 332 cycles. And what you can see is of those patients that have returned to thaw, only 29% are single, with 71% returning in a relationship, same sex or heterosexual. We also can see that while social is still the dominant group here, we can see of those returning to thaw, 52% originally froze for social reasons, and now clinical and medical comprises a third, and incidental is 15% of those returning to thaw. And equally, when we take a look at those parameters again, we can see that people who originally froze for social reasons return to thaw at an older age, and they store their oocytes on average for a longer amount of time. And the number of MET2s stored on average is similar between those groups. So when we take a look at this a bit further, obviously I just went through that first line there, which is the proportion that they comprise of the thaw cycles. But when we start to take a look at them returning for warming as a proportion of those who originally froze, only 5% of social freezers have returned to thaw at our clinic. 37% of clinical and medical have returned, and 78% of incidental freezers have returned to use their eggs. We also see that clinical and medical make up nearly half of freeze-all embryo cycles. This is unsurprising because for clinical freezers, those who are batching their eggs, we do see that they are doing this primarily for PGTA cycles. So this is why they are undergoing freeze-all. And we see that social are comprising the greater half of fresh transfers as well. So moving on to the embryology KPIs, as I stated, 299 patients completed 332 thaw cycles. This was a total of 3,268 MET2s thawed with an 84% survival rate. These went on to form 1,944 2PNs, equating to a 71% fertilization rate. And these went on to form 948 blastocysts, reaching a 49% blastulation rate. 61% of these cycles aimed for a fresh transfer, and 84% achieved that fresh transfer, with 43% of cycles having supernumerary embryos available to freeze. The remaining cycles underwent freeze-all embryo approach, with 56% going for PGT, and the remainder not, with 458 embryos frozen from these cycles. So again, delving deeper into these two cycle types, you can see that the age at which they froze and the age at which they thaw between these two groups is comparable. Where we start to see differences is that people who went for freeze-all embryo cycles stored their eggs for a shorter amount of time, Again, I think this is from a large proportion of the clinical and medical freezers being a part of this cohort. And similarly, people who underwent fresh transfers stored for longer. This will probably be due to the majority of social freezers being a part of this group. And again, there are no differences in relationship status, pre and post thaw between these groups either. So moving on to clinical outcomes. We completed a total of 167 fresh embryo transfers, and the collective live birth rate per embryo transferred for fresh transfers was 17%, which is nearly identical to our governing body, the HFEA's recorded national average for fresh IVF cycles in 2021, which was 18%. Unsurprisingly, the under 35s are achieving the highest live birth rates, 26% live birth rate per embryo transferred, 59% cumulatively. As you can see, the over 40s have a low live birth rate, both per embryo transferred and cumulatively. This was unsurprising to us because, given the existing literature, this group has consistently performed poorly in thaw cycles, with some papers even reporting a 0% live birth rate in this group. So this was expected for us. And indeed, when we performed an optimistic prediction analysis that makes the assumption that if patients were to persist in treatment and not drop out, what live birth rate could they achieve? You can see that, unsurprisingly, the under 35s are reaching live birth rates of up to nearly 80% after 3 transfers. While if you look at the 40+ group, after 1 transfer, their live birth rate plateaus in these fresh transfer cycles. However, when we start to look at the freeze all embryo cycles, of which we had 130, with 82 FETs completed from these, again, unsurprisingly, you can see that the under 35s are achieving the highest live birth rates. And collectively, for all ages, the live birth rate per embryo transferred was 27%. But again, I want to draw your attention to the over 40s group, because here, surprisingly, we are seeing that they are reaching live birth rates of nearly 30% after 2 transfers. So we decided to look at this a little bit closer, and perhaps unsurprisingly, all the live births in the 40+ group were from a euploid embryo. And indeed, when we stratified the frozen embryo transfers by PGT, you can see that PGT more than doubled the live birth rate in the thaw cohort for FETs. And again, just displaying this in table format, and again, just focusing on this group to show just the euploid transfers in this age category, they're now achieving a live birth rate of 36% per euploid embryo transferred and cumulatively 42%, which is a very good result, and as far as I'm aware, the highest result that is being reported for this age group so far. So to put all of this in context with some of the key studies that have emerged over the past few years looking at thawing, you can see there's a beautiful consistency and a similar narrative that's being reported, where we can see of those that are thawing, they originally froze around the age of 38, that the age that they return to thaw is between 40 to 42 years old, and patients are on average storing their eggs for between 3 to 4 years. We are the second largest, to our knowledge, cohort size for thaw cycles, and the largest so far in the UK. And surprisingly, we believe we are the highest reporting of return rate. I mean, we were surprised and thought 14% was quite low, but here you can see there are some reports of half the return rate of what we have seen. We also did a comparison of live birth rates. It's quite difficult because everyone reports in different manners. And we did note that ours are slightly lower than the other studies, but we did want to note that this may be due to other studies having a greater number of MET2s frozen and a greater number of oocytes thawed per cycle than us, which, as we know, there is a relationship between egg number and live birth rate. So this is probably the cause of this. So to conclude, we're seeing that there is an exponential increase in the number of patients freezing their eggs, but they are not really necessarily returning to thaw. There is a consistently low return rate of patient use of their eggs. We're seeing that the majority are freezing for social reasons and the majority are returning in a relationship. But the key message I think we're seeing here is the outcomes are comparable to fresh IVF, and therefore when we look at clinical counsel and guidance of patients, I think we are getting to a point where it's comfortable to be able to counsel them in the same manner as we do for IVF, because the messages seem to appear the same. Egg age matters. Patients freezing below the age of 35 are achieving a very high live birth rate, and PGT is significantly increasing live birth rate in patients that are freezing their eggs over 40, which is kind of the way we counsel our IVF patients. So with that, I would like to thank my team, especially Trina Shah, my co-first author, our lab manager, Eleanor, Dr. Ahuja, and Nick. Thank you.
Thank you, Jemma, for the beautiful presentation. It's, I mean, working in the field, it's always, we are struggling with numbers. So to get the patient data enough to really draw conclusions, it is beautiful always to see. So yeah. Congratulations for the beautiful study and the excellent presentation. I see there are already questions coming, and yeah. I'm sure we will have an interesting discussion coming, but I will just comment here that two aspects. For me, is it is surprising that I mean the knowledge and the media information it's growing. I mean it's endless, and also the social egg freezing is getting more and more popularity. But it's surprising to see that the return rate it's still rather low. And the other thing, I think your study is encouragement for many patients, and also that the egg freezing it is actually an option also for oocyte freezing, option for older women who are maybe starting to think about all the preservation of fertility later in the reproductive age. So to see the results of good birth rate results in older women than 35 and over 40, I think it's very encouraging.
Yes, thank you. Yeah, I completely agree. It is clearly, you know, like you said, in the media, but even just, I'm kind of the age where people are my age are even talking about it now. You know, I'm 27, and I've seen even from our data, you know, I recorded that people are freezing at 37 years old, but if we look in 2023 and 2024, which is past the scope, it's now getting to 35 rapidly with the exponential increases. So people are freezing younger, and these are mostly for social reasons. But yes, it is really encouraging to be able to show that even if you do decide to delay your decision to freeze, there's still hope that, you know, you can take home a baby. So that has been really nice to see. Yeah.
Thank you. Thank you very much. And we continue with the discussion in the end of the webinar. And we will move on to the next speaker. I would like to hand over to Catherine Aiken, who is an active clinical scientist at the University of Cambridge, UK, leading a research group that focuses on understanding the long-term outcomes of complex pregnancies. She has published many papers, over 50 peer-reviewed papers, and is the chief investigator of several studies, and is one of our section editors of Periconception, Pregnancy, Children Outcomes section. And she's going to give a short view of this section. Please, Catherine. Please unmute, Catherine. Thank you.
Thank you very much. So I tend to think of this section as giving a really wide perspective on reproductive health. And a key goal for me as section editor is to expand our knowledge of how the very early environment from preconception onwards influences health outcomes beyond the immediate pregnancy and neonatal period. And while understanding these immediate outcomes is extremely important, I'm really keen to emphasise the children aspect of this section, the periconception, pregnancy and child outcomes. And I'm particularly excited to receive the studies that we see that use novel methods to explore the longer term outcomes of complex conceptions and pregnancies. And this is an area that's really difficult to study well, but of course it's of critical importance in improving population health overall. And Reproductive Biomedicine Online is really well positioned to lead the way in publishing research in this as an emerging area. In humans, we have long generation times, we have shifting global demographics in maternity populations, and we have advances in pregnancy and neonatal care over the past 30 to 40 years that mean that it's a real challenge to understand adverse outcomes that babies that are born today will face. But of course, it's vital to optimize their periconceptional and pregnancy environment with their life course health in mind. And that's what this section really tries to address, that we're now at a stage in this field where we can identify multiple factors, ranging all sorts of things from maternal stress through to nutrition, that can influence long-term health outcomes for both mother and baby, particularly in terms of cardiometabolic health. And we're beginning to understand more about brain development and neurodevelopment. And we've got these exciting new mechanistic insights beginning, particularly an understanding of the interaction between epigenetics and genetics and how they shape later risk, especially in the face of different challenges in the early life environment. A key example is nutrition during early development. We're really interested in that, both maternal nutrition during pregnancy, nutrition in periconception phases in both parents and in the neonatal phase. And we see a really wide range of dietary challenges across different global settings that have been linked to programming of long-term outcomes. And of course, we're all familiar for a long time with isolated micronutrient deficiencies, low folic acid or iodine, and their association with developmental or neurodevelopmental issues. And of course, we have interventions for those population-wide food supplementation and fortification. But a really fascinating aspect of these studies is the idea of studying the impact of stresses, environmental factors, and lifestyle as a whole. And a fascinating aspect of those studies is, despite the fact that we see a really wide range of interventions, we very often see a common offspring phenotype that results in a final common pathway linked to later life metabolic or other dysfunctions. And it's strikingly similar to that observed accelerating populations worldwide. And that's one of the things that we urgently need to understand in terms of future population health, particularly as we begin more to manipulate the early environment, and novel and emerging reproductive technologies really feed into this. And this is the kind of issue that this section is designed to look at and to tackle. It's highly relevant to the trends we see today in many maternity populations worldwide. On one hand, we have growing populations exposed to food insecurity, which is enormously challenging on a whole host of levels. And we also have growing numbers of women entering pregnancy who are living with obesity, who are much older, and a really interesting shift in the challenges that maternity populations face. So to best serve those populations and the future generations that results, we really need to understand the impacts of these beyond the immediate effects. And a really interesting example, particularly in the context of the overall aims of reproductive biomedicine online, is the longer-term outcomes of pregnancies conceived using new reproductive technologies and exposed to a variety of perhaps novel stimuli. Most obviously, maybe culture in vitro, but there's really interesting developing literature in this highly active area, with additional interest in paternal interventions, donor conceptions, and of course, maternal nutrition remains highly topical, particularly in view of the wide assortment of supplementations and additional treatments that many women have during fertility treatment. Reflecting on the scale of life course health, of course, we haven't got a population of older adults that have been conceived or exposed to any of these techniques. The oldest children anywhere in the world conceived by in vitro fertilization are only in their 40s. And so what we tend to rely on very heavily is either animal models or early emerging signs that predict later adverse outcomes. And both of these approaches have obvious methodological limitations. And that's why we're always looking for studies that have novel methodologies and new ways of tackling these issues. And there are now some really interesting, emergingly, prospectively designed studies in humans that address these questions. And a really good example of that comes from the Rotterdam Periconception cohort. The insights that we gain from it have impacted many aspects and dimensions of early development and are continuing to emerge. And from the Rotterdam Periconception cohort, I'd now like to introduce our next guest. Melissa van der Windt is a medical doctor, and she completed her PhD in May 2023. She's currently working as a gynecologist in training in the Erasmus Medical Centre in Rotterdam, and she's the lead author on the next paper, which looks at the impact of periconception, maternal and paternal alcohol consumption. Melissa.
Yes, thank you for your introduction, and I hope you can see our screen now. And of course, also thank you for the opportunity to present our recently published article during this webinar. Let's start with the question, is drinking alcohol during pregnancy, what is recommended? It is not that long ago that the NHS guideline told us, avoid alcohol altogether, never more than 1 or 2 units once or twice a week. That guideline has now been updated and now suggests that there are no safe limits of drinking alcohol during pregnancy. However, in medical science, there are doubts about the strength of this evidence and whether it is convincing enough to make such strict recommendations on drinking alcohol during pregnancy. But what do we know? The main points of uncertainty are about timing of alcohol consumption and the dosage. Is it, for example, harmful to drink alcohol in the first trimester of pregnancy, in the second trimester, or maybe in the last trimester of pregnancy? Or is it even worse to drink alcohol in the preconception period? Another question that may arise, is one alcoholic consumption already causing negative effects, or is only moderate or heavy drinking impacting fetal development? And what do we know? There are also things we do know for sure concerning alcohol consumption during pregnancy. The fact that in Europe around 14% of women, and in some parts of the world, like South Africa, up to 50% of all women report drinking alcohol during pregnancy, shows the significance of the public health concern worldwide. We all know that prenatal alcohol exposure is linked to poor pregnancy outcomes. And one of the most impacting long-term neonatal outcome is fetal alcohol spectrum disorder, but it's also associated with miscarriage, fetal growth restriction, and congenital abnormalities. But we indeed do not know how and when these consequences arise. You can imagine that these complications result in more frequent hospital visits, more diagnostics, poor pregnancy outcome, but also more healthcare consumption during the whole life course. And the exact costs are unknown since we do not know how big this problem really is. However, this underlines the societal impact of alcohol consumption during pregnancy. I want to zoom in on the periconception period as a crucial period into lifelong health. The periconception period is the time window from 14 weeks prior until 10 weeks post-conception. During this period, a lot of important processes take place, like the gametogenesis, conception, early embryogenesis, and placentation. Both genetic and environmental factors can influence those processes and can impact fetal health and development, but also the health of the newborn and even the health of the future generations. Lifestyle factors, like alcohol consumption, are an example of an environmental factor that can have detrimental effects in periconception period. Here you can see an overview of the processes taking place in the periconception period, namely gametogenesis, fertilization, implantation, embryogenesis, and placentation. Now let's discuss the article recently published in the RBMO. It was concerning periconceptional, maternal, and paternal alcohol consumption and embryonic and fetal development. The aim of this study was to investigate the impact of maternal and paternal alcohol consumption in the periconception period and the effect on embryonic and fetal development, assessed using 3-dimensional ultrasound and virtual reality techniques. This study is embedded in the PREDICT study, which is a large cohort study. Participating patients, both women and their partner, filled out 2 questionnaires at the beginning of pregnancy. Later on, we performed ultrasound, 3D ultrasounds, at 7, 9, and 11 weeks of gestation. They filled out another questionnaire, and at 20 weeks, another ultrasound was performed. And eventually, a questionnaire is filled out, and we extract the reported birth weight to use in our analyses. So the patient and her partner filled out 2 questionnaires at the beginning of pregnancy. One periconception questionnaire, including information on the type of alcohol beverage and the frequency of consumption during the prior 3 months, and covered alcohol intake in the periconception period. The other questionnaire is a validated and extensive food frequency questionnaire and covered the prior 4 weeks, so the first trimester of pregnancy. We also used the Goldberg cutoffs. This was used to identify dietary underreporters. This calculation relies on the hypothesis that energy intake equals the basal metabolic rate multiplied by the physical activity level. The basal metabolic rate was calculated using the Schofield equations, which take sex, age, height, and weight into account. For the physical activity level, a fixed value of 1.55 was used, which is equal to a light activity level. Daily energy intake was measured using the FFQ, and the participant was considered a dietary underreporter when the reported daily energy intake was below the individual energy intake cutoffs, and underreporters were excluded from our analysis. Then I want to continue with the innovative technique we have used to measure embryonic and fetal development. We used virtual reality because this technique has various advantages. We use a projected hologram, which makes depth perception and interaction possible. It is suitable to use for complex measurements, and it's validated in the past 10 years. I will show you how the technique looks like. Virtual reality uses an interactive computer system simulating the real world using hand gloves, a joystick, and a helmet, and multiple screens surrounding you. In our case, we use the iSpace. That's the room which makes virtual reality possible. You are able to see holograms with real depth perception. Here you see one of our colleagues in the iSpace, and you can imagine how helpful it can be, for example, in diagnostics, but also in counseling with parents expecting a child with an abnormality. This is a video of my supervisor Melek showing the hologram of an embryo. As you can see, it's interactive, and you are able to rotate the embryo and to study it in very detail. We measured the ground rump length and the embryonic volume at 7, 9, and 11 weeks of gestation using this virtual reality technique. On the left, the yellow line, that's the ground rump length, and the whole green area, that's the embryonic volume. We use conventional 2D ultrasound data to analyze the fetal development around 20 weeks of gestation. We use the head circumference, abdominal circumference, femur length, and estimated fetal weight. As I said before, we use Goldberg cutoffs to detect dietary underreporters. Moreover, we composed a directed acyclic graph, a DAG, and to select a minimal sufficient adjustment set of variables that would allow the identification of an unconfounded effect of parental alcohol intake and the effect on prenatal outcomes. We analyzed periconceptional alcohol exposure as a categorical, dichotomous, and continuous variable. And we used linear mixed models to analyze the fetal and neonatal growth trajectories. This figure shows us how our study population was created. We started with 1,744 women and 1,480 men. For various reasons, women and their partner were excluded. For example, because of multiple pregnancy, because they experienced a miscarriage, or based on their food frequency questionnaire, and their intake might be underreported. Eventually, we did analysis with 1,141 women and 978 men. The mean age in our study was 32 for women and nearly 35 for men. The majority had a Western origin and were highly educated. Mode of conception was predominantly natural or intrauterine insemination. I want to zoom in a little bit more on their alcohol consumption, and first in the periconception period. Among women, most of them did not use any alcohol or only in low amounts, and the majority of men consumed low or moderate amounts of alcohol. We categorized the maternal alcohol intake. Low is below 35 grams a week, moderate is below 70 grams a week, and high is above 70 grams a week. And 1 glass of wine contains around 20 grams alcohol. Paternal alcohol intake was categorized as low, below 70 grams a week, moderate between 70 and 140 grams, and high was above 140 grams a week. And this was based on international recommendations on alcohol intake not being pregnant. During pregnancy, most women reported low alcohol intake, and men reported low to moderate alcohol intake. The effects of maternal alcohol consumption on embryonic development parameters are summarized in this forest plot. We analyzed alcohol consumption as a dichotomous, continuous, and as a categorical variable. And only crown rump length showed a slightly significant association with high alcohol intake. We also analyzed the effects of maternal alcohol consumption on fetal development. As you can see, moderate alcohol consumption showed negative associations with mid-gestational fetal development parameters, and they were also significant. We also analyzed the model including maternal and paternal alcohol consumption. Here you can see a table with alcohol consumption as a continuous variable. No significant associations were found between alcohol consumption and embryonic development. This table shows the results for the associations between paternal alcohol consumption and fetal development. Most betas of maternal alcohol intake are negative, and for paternal alcohol consumption are positive, and some of them were also significant. So what did we conclude? Maternal and paternal alcohol consumption during the periconception period is not associated with crown rump length and embryonic volume. And regarding fetal development, we found that moderate maternal alcohol consumption during the periconception period is negatively associated with head circumference, abdominal circumference, and femur length, and estimated fetal weight. Paternal alcohol consumption during the periconception period and pregnancy is positively associated with abdominal circumference and estimated fetal weight. Some strong points about our study is that we had a large sample size of around 1,700 women, and we used innovative techniques like the virtual reality technique. We used 2 questionnaires, and one was a validated food frequency questionnaire, so we were able to analyze alcohol consumption before and during pregnancy. As I told in the beginning, alcohol consumption during pregnancy is stigmatized. Since we used self-reporting questionnaires, there might have been some report bias. And at last, we showed less convincing results compared to animal studies. This might have been caused by underreporting because of the stigma around alcohol consumption. What should we do in the future? We should always remember that alcohol is a strong teratogen, and consumption during pregnancy should be strongly discouraged, and guidelines should be clear about this. In the Netherlands, for example, we established the task force Alcohol-Free Start, which supports healthcare organizations in detecting alcohol consumption during pregnancy. Lifestyle interventions might support women and men stop drinking alcohol and should be offered in healthcare settings. And biomarkers are already widely studied, but in the future, it might be a reliable alternative to self-reporting questionnaires to avoid report bias. I would like to thank all women and their partners who participated in the Predict cohort study, and of course, our research team. I thank you for your attention, and we would like to answer your questions.
Thank you so much, Melissa. That was a fantastic presentation. I really enjoyed it, and it's such a delight to see such a well-conducted, absolutely thorough study, and thank you for going into all the details about it for us. I have a question to begin with, if I can. I wondered what the correlation looked like between maternal and paternal alcohol consumption within the couples in your study. Was there high concordance between parental alcohol consumption? And if so, would a household level intervention perhaps be less stigmatizing and maybe take the pressure off women a little bit in terms of making things safer in terms of alcohol consumption in early pregnancy?
So if I understand you correctly, Catherine, you were asking if we looked at if the fathers drink, if the mothers also drink, or vice versa. Yeah. We didn't report that in the article, but what we checked this, of course, because this is a very interesting topic. And what you see is that especially when the woman drink, you see that the partner mostly also drinks. It's not always the other way around. Yeah. Because also regarding the amount of alcohol drinking, but when you see that women drink, we see this. And what another very important point to notice is that you see that this is a really different problem, or we need a really different approach from other lifestyle factors, because not only low educated women or their partners are drinking alcohol, but also the very high educated women are drinking, especially drinking the alcohol.
Mhm.
I think you also need to take this into account when you are thinking of approaches to handle this problem.
Yeah, absolutely. It's a bit like the BMI correlations between couples, isn't it? That you tend to get lots of lifestyle factors that affect the household on an environment level, and not simply putting it all on the mother's side. Really interesting. Thank you so much. I think we're now going to open it up to a wider question and answer for all the speakers. Is that right, Nick?
Indeed, yes. Thank you, Catherine, for taking us through that session and for giving us such an excellent overview of the section of which you're an editor. We really enjoyed it. It's been, as we said, quite a mix of topics this evening. It's one of the things that characterizes these webinars and says a lot about the journal too, of course. But we now have some time for discussion, and it's been great to see your questions coming in. We'll try and deal with as many as we can, but I think some people do need to get to bed within the next few hours, so we can't keep going forever. But we'll try and take about 20 minutes to discuss some of the questions that have come up. And I think it'd probably be reasonable to start with our first speaker and our first topic, which is Münevver Serdaroğulları, and she has generated a lot of questions. Muna, I hope you're still with us. I think a couple of themes that emerge in the questions. I think one of them is around whether or not you feel from analyzing the different protocols, there is at least some consensus growing about the concentration. One of the questionnaires has come in who's from a different specialty has talked about it. Really, you can only define it as being concentrated if it's 5 times the background concentration, and others have talked about 7. There is a variation there, but are you seeing any consensus emerging around about what the concentration should be?
To be honest, I don't have any expertise and experience to comment that this should be the right concentration. But maybe when we do more RCTs and standardization protocols, we can end up the right concentration, to be honest. Because we see range of concentration between the studies. So it is one of the negative things with the PRP. So everyone is using a different concentration. So I cannot say the right concentration is what it is. So
right. So there really isn't we're not really in a position yet to recommend.
No. So sorry. So I wouldn't. Yeah. If I say, I would be wrong.
Okay. I'm not quite sure whether you've had experience in your clinic of using it, but one of the questions that's come in, and I think people quite often wonder, is how it works in the clinic, to what extent offering PRP treatment is disruptive to the processes in the clinic. And I don't know if you're able to do this, Mona, but one of the questioners was asking if you could briefly talk us through what the steps would be if you decide on doing PRP. What stage do you do it? How does it affect the work in the lab?
For ourselves, we don't do in the lab. We have a separate lab that does it, the PRP. To be honest, our doctor decides regarding to patients' history. So some of the time she does the, as far as I know, ovarian, and some of the time she does the for the endometrium. So the patient comes, and after taking the history of the patient, our doctor decides.
And once they've decided, are you aware of what the process is in terms of, what day is the blood taken? Presumably it's the patient comes in the morning, has the blood taken, and then has the treatment the same day. Is that the way it happens, or is it?
It is normally when 1 or 2 days later that she does it.
Right. Okay. So it is frozen and then thawed and then.
Some of the time, no. Some of the time they do on the same day, and then the second time as well. So it can be like on the same, but not the frozen. We don't do the frozen. We do the fresh. But if the subsequent cycles that can.
So from the limited experience you've had, is it something that you feel most clinics can cope with quite easily and fit it into their managing patients and clinical operations?
Yes, they can do, but again, it depends on the doctor.
Yeah. Okay. It's one of these areas, isn't it, which is quite common in IVF, where an exciting new technique comes along, which often has quite a compelling biological rationale. We all jump on it and think, well, it can solve all known problems, endometrial thickness, ovarian rejuvenation. Do you have a sense, of where you think, if it is going to have a place, what's its most likely position going to be? Is it something that's going to really offer more potential in ovary or endometrium or elsewhere? If you were to guess 10 years from now, are we not using it at all, or maybe we're just using it in the endometrium?
To be honest, for my opinion, if we do more standardized protocols, and if we stick the one standard protocols, and if we offer the ovary, endometrium, and the RIF, it can be used. But again, your experience as a gynecologist is more than me, because I'm looking at the subject objectively from out of the embryology part. So I would use every opportunity to benefit the patient as an embryologist. I am open to new things and try things, but as a doctor, it is important your opinion as well.
Well, that's good.
Yeah.
Good to know. It's one of these difficult ones because a lot of people are asking you for your recommendations on different aspects of the protocol, and it's very clear from your presentation and from what you've been saying that at the moment it's not really possible to make any specific recommendations. Would it be fair for me to conclude before we move on to discussing Jemma's paper that if we are using it, we should be trying to do it in a research setting, making sure we're collecting the right data so that conclusions can be drawn and we can learn about this technique?
Yes, because even I have been searching since our deadline 2022 the other papers. And there are lots of things in the protocols that we just highlighted in our paper. Again, everything is different, so for my opinion, it should be standard. Yeah.
Standardize and then test.
Yeah, okay. Exactly.
Very good. Well, I think that would be a great movement to move on. And thank you, Mona, for answering those questions. And I'm sorry to all of those who did ask questions which we haven't been able to address. If we've got more time, then we'll see if we can come back to some of them. But I'm going to hand over to Signe now, who's going to talk to Jemma a little bit about some of the questions that have come in about her presentation. Signe.
Yes, thank you. Yeah, we come back to the exciting paper with really, I think, really important results for the clinical setting. So going through also the different questions, and I'm sorry we cannot address all the questions, but trying to summarize, we come back to the return rate. The low return rate, it's a good or bad message. Does it mean that the couples don't need more the eggs or oocytes? They have found a natural way of conception, or they have given up, or bad news, let's say, of the low rate is that are we failing in something? We are good in advertising the possibility, but somehow they are not returning back. So what I mean, I know you are not the medical doctor and dealing with the patients daily, but do the data tell you anything, or working in the big clinic give you any?
Yeah, I mean, of course, I can only give speculation and my own opinions, but obviously there's probably a mixture of both. But I would say primarily, I do think it's not that the clinic is failing. I think that, as I was just saying, everyone seems to be talking about it. Everyone's aware of it, even everyone my age. So I think everyone's aware of freezing. I think that it is, and especially because it's for social reasons, and perhaps it's not a narrative that's very popular, but I do think that it is this reassurance for patients to freeze their eggs. It's that backup option. It's not plan A, it is plan B. And therefore, if they can find plan A, they never need to go for plan B. And I think that while now everyone's getting that reassurance that egg freezing possibly does work, they're increasing in the numbers being performed because they think, if I need it, it works, or, you know, it's a viable option for me. But no one wants that to actually be the plan that they have to go through in the end. That's the narrative I'm feeling, that it's providing those patients that reassurance as they go through life. And if they find plan A and they conceive naturally, that is what is happening, I believe. And those that are returning, they're obviously returning, as we're seeing, at the age of 40. I think, you know, they've been searching for plan A, it's not worked. And they're returning at that older age for those that it just, you know, unfortunately hasn't happened for them and they have had to resort to plan B. But that is my hypothesis of why the return rate has remained low.
So we take it, it's a good message. It's a good.
I think so. I think so. Yeah.
Yeah. Okay. So, and then there have been several questions about the time effect, the how long they are frozen. Have you seen any correlation? I'm sure there is, you know, you cannot analyze everything, but if it's longer time frozen, the oocytes, does it give a worse outcome? Do you see any of this time effect?
Well, I think time as itself, you know, like 10 years, 5 years, I think, I have looked at it, no, but it is difficult to measure because obviously you're then factoring in how far back did they freeze their eggs and is it the protocol, evolution that is the problem rather than the time itself. So, you know, for example, I'm sure maybe there are questions about it, but, you know, like our survival rates have improved over the years. You know, I know I reported an average of about 84%, but, you know, in the more recent years, we're averaging, you know, in the 90s. So you might see patients, you know, obviously stored in 2008, returned 10 years later, they froze in 2008, maybe their survival rates are lower than someone who froze in, you know, 2015 or 2017.
Yeah, exactly. There was a question regarding, do you see difference from the oocytes frozen 15 years ago versus frozen now in the recent years?
Of course, yeah, it's not massively
and you don't know, is it
but...
effect of the freezing or is it effect of the protocol?
Exactly, and that's something we don't know. I mean, I do think it is protocol evolvement. You know, it obviously has evolved. In our study, everything was vitrification, but you know, our embryologists have all evolved in the protocols and everything, and especially since 2017, it's become more standardized. But yeah, so it is difficult to say with confidence whether it's time or just the protocol that was used.
Yeah, and also just passing fast some more questions. Is there any, have you noticed the pandemic effect on the results?
So it's something I looked at because I had that graph and I went back and looked at it. And obviously we saw a dip, of course, in the freezing. I think probably everywhere we saw a dip in the freezing. It's difficult to say because the increase is dramatic after 2020 in freezing. But whether that is just, it looks almost like it is in the trajectory of the way it was going anyway. Obviously, we saw thawing didn't change. No one returned to thaw more after the pandemic. But whether, the increase is rapid, you know, it's still going. Whether that's an effect of the pandemic or not, I'm not sure. But obviously, we saw a dip.
And then I highlight the last question that is from Linda Stevens because it's very specific. So I will ask there if there were more patients with no embryo available for transfer in the 14+ group with BGTA compared to the 40+ group without BGTA. So if so, she suggests that only reporting live birth rate per transfer could lead to an overestimation of the benefits of the BGTA.
Yeah, it's a good point. It is a good point, and you know, there's always going to be controversy with PGT, of course. I mean, I did actually just take a look, and I think about 50% of the 40+ group had all aneuploids, which I think is actually quite good for the 40+ group. I think usually we'd expect about definitely less than 50% having euploids. So that was quite good for us. But indeed, yes, you have to factor in that group. It's a selection tool. There's going to be a lot of embryos and a lot of cycles, perhaps, that there's not anything to use. I guess, the selling point isn't to promote PGT with this egg freezing. By no means. It's the same conversation you should be having for routine IVF with patients. There's always the risk that you're going to end up with nothing with PGT. It's just, I guess, sometimes seen as a cost benefit, so that you don't undergo unnecessary transfers with all your embryos are aneuploid. But yeah, so that has to be factored in and spoken with the patient and weighing all of that up. But yes, of course, there are going to be patients with all aneuploid cycles in that group because aneuploidy is high in that group.
Yeah. So I will wrap up this part. Thank you again, and I hope that this study will inspire many other clinics to look at the data, because finally what we need confirmation, and I think your paper will be guidelining them. Thank you very much.
Thank you.
I will pass to Catherine to go through the last part.
Thank you. Melissa and Melek, thank you so much again for that lovely paper. We've got some really interesting questions about your work. There's a couple of people asking about recall and recall bias with this kind of questionnaire, and about how we can validate that and the kind of methodologies that I wonder if you can just talk a little bit around how you can be sure that people are remembering what they drank and whether they're reporting it to you.
Yes, that's why we ask it, actually in a study, we ask it several times, and we hoped in this way, because we also compared the questionnaires and we also asked it by using different questions. And the first questionnaire we were mentioning was asking 3 months back. So then you can imagine that recall bias can be really introduced. And the other one was asking back for a shorter period. But recall bias is always a problem. But I think in this case, when you look at alcohol consumption during pregnancy or during the periconception period, it's more important to think about the underreporters, because people are afraid to mention that they drank during pregnancy, even when they are it's a study. So this is also one of the reasons in another study, we also had access to the biomarkers. So we are analyzing that at the moment. It's a South African study. So I think it's very important when you are doing research with questionnaires, that you try to find biomarkers, and if there are validated biomarkers, to use them, and also ask for money in your grant applications to collect them and to analyze them, because I know that they're very expensive, and it's sometimes very hard to, for instance, for alcohol, it's one of the biomarkers is meconium. It's very hard to collect, but I think it's really worthy to do it.
Yeah, no, absolutely. And that biobanking of samples is so useful in so many ways that it's absolutely, I fully agree that as part of a grant application, super important to do that. Also, the way that questionnaires are presented to people can change the response so much as well. Can you talk a little bit through how your participants were given the questionnaires and so on?
Yeah, so we give them the questions. We do not only ask them, did you drink, yes or no, but also what did you drink, how much did you drink, and what kind of types of alcohol did you drink? Because sometimes we also notice in the questionnaires, because they are all also checked by our nurses, and so when the questions are not filled in, we ask them again, and then fill it out together, or they fill it themselves again. So by reminders. And for instance, we noticed that sometimes people thought that beer is not alcohol, so they were just saying no, and then we told them, oh no, it's also included, and then they say, oh okay, then I have to answer something else. So you really have to think about how you ask the question, and to give a lot of examples or images, also depending on the population you are examining, that you also include, for instance, pictures and what is a glass, how much is it filled. So lots of stuff to think about. But you also have to be aware that you don't ask too much, because it's a questionnaire and people must not get bored and fill out the questionnaire for the study. So you have to find a good balance in this.
It's all in the methodology.
Yes.
We have another interesting question about other factors, particularly genetic factors that might affect how the alcohol consumption actually interacts with the effects on the fetus. And we know that there are quite a lot of common polymorphisms that affect alcohol metabolism and so on. If I'm right, you collected DNA for this cohort?
We have it, but we didn't analyze it for this part. No.
Is that something that you could do, or something you'd be interested in looking at?
I think we will be. But we have, because this is a very large cohort where we also analyzed DNA and epigenetics for other reasons, we are almost out of our samples to do this, but it's really interesting to do, I think. But
yeah,
so much easier correlations, I think, like smoking is also a very important one. If you don't think about genetics, but about other factors who can influence our outcomes, or
your rate of paternal smoking was pretty high in your cohort.
Yes.
Were you surprised by that?
A little bit. We're a little bit surprised, definitely. So there are also a lot of people saying, yeah, is this the effect of the alcohol, or is it smoking? Because you see that smoking and alcohol is quite correlated to each other. So that's why we also try to figure this out with sensitivity analysis, but the outcome stayed the same. So we really believe that also alcohol on its own has this effect.
And just finally, because I think we're going to wrap up in a moment or two, there's a question about a safe level.
So I'm also part of this task force, alcohol-free start for everyone, for every child in the world. So I would say no.
Okay.
I think it's very important to give this message, give a very clear message to our mothers and future fathers, because otherwise it's very hard to see. And I really also don't think that there is a safe actually amount. So, but even if it's not proven, or the proof is not that hard, we should give a hard no, and work on eliminating this risk factor.
And what will we say to the women who didn't know they were pregnant and then realize that, oh dear, they've been drinking wine the last 2 or 3 weeks?
So we can say that we are very happy now that they know that they are pregnant and they can fully eliminate it, and that we will keep up. We will control the growth, of course. We in our practice, so at our university, when we notice that women drink alcohol during their pregnancy, or they tell it by themselves, we measure the alcohol amount in the blood and look at. We perform a PET test. And then we can see how much they drink in the past 4 weeks. This test controls for alcohol exposure during the last 2 to 4 weeks. And we also test it within the baby when the baby is born in the meconium. And we also do the PET test in the umbilical cord, so we can say a little bit more about what the risks are of the baby. So the pediatricians are also involved in this guideline we are using at our university. So together then we can make a plan for the baby for the long term. For the checkups, and of course the withdrawal after pregnancy if they use large amounts of alcohol. So we also have really built a policy on this problem.
Great, thank you so much. I think probably we need to wrap up there, Nick. Is that right?
Yes, I think we do. Fascinating discussion, and I know many people have stayed very late to listen to it. So I'd like, first of all, I would like to thank everyone who logged on this evening to come and listen to these talks wherever you are in the world, for doing that. And I hope you really enjoyed it. It's an important part of RBMO that we reach out to people. And those of you who haven't already signed up online to RBMO Insights, which is our monthly newsletter that gives you a very nice summary of papers that have been published or up and coming, puts them into context too. please do that. It's hopefully a useful extra part to the journal. But tonight, I think, I hope you'll agree, we've been lucky to have wonderful speakers and moderators. And I'd like to thank Münevver, Jemma, and Melissa and Melek for preparing their talks, for participating in the discussion afterwards, which was so interesting. And of course, to Catherine and to Signe, who moderated the discussions so well. Thank you all very much. And I think I'm going to hand over Signe for the next round of thank yous.
Yes, I will be thanking our team from AIFPRI, not to forget them, big work behind the scenes. Thanks for organizing this event. And I would name not everybody, but let's say the key people: Jax Cohen, Duncan Nichols, Peter Nagy, Marianne Servaites, Thomas Elliott, Fran Farley, Violetta Soura, and Gilles Palmer. Thank you very much. And Catherine, please, for you, the last word.
The last word
Yes.
is to remind everybody that the next I3 webinar is next week on the 17th of September, and it's about non-invasive genetic testing of the human pre-implantation embryo, which is a fascinating topic, and I'm really looking forward to that. Don't miss it. Thank you everyone for joining us tonight.
And before ending, I would like to thank Nick Macklon for leading the session. He, of course, cannot thank himself, so I will take the task. Thank you very much, Nick.
Thank you, Signe, and thank you, everyone, and have a very good night.